Our afternoon panel discussion, you know them all by now, Dr. Barry O'Driscoll, Dr. Kevin Moran, Dr. Mickey Collins and Professor Mick Malloy. So we did think that maybe one of the best things for the afternoon for this session would be for it to be question-led. So I will open the floor pretty much straight away if anybody has any specific questions that you want to talk to everybody about. But Barry, you've obviously been at concussion conferences all around the world over the last decade or so. And it's obviously something that you've got a very passionate belief in. The stuff that you're hearing today, does that give you a sense that at least we're beginning to get to grips with the bigger problems?
Well, two things. Is that on yet? It's opened up a completely new dimension for us in UK and Ireland in what they're doing in Pittsburgh, where they're treating the concussed player as an individual and not as just a broad entity. And this is fantastic. And we haven't got the finance either in the UK or in Ireland to do that at this stage, but we're already starting it with Niamh and with Mick Malloy, and there's the clinic in Dublin out at Santry that's starting this, and it's terrifically lifting to be able to have this to aim at, because I think we had become into a bit of a lurch with concussion and thought we know so little about the brain, but we've learned a lot here, and we have an awful lot more to hear. It's interesting education. It's hugely hard work getting this across, and I think it's been a hard work getting it through. And even, again, I spend most of my time in the UK now talking to teachers and parents there. They have no idea about this, and in fact, they're only beginning to catch up with what we started to learn 3 or 4 years ago, and that's got to be concentrated on again and again and again. And my own personal interest has been, as you may know, has been the child or the adult with the slightest sign or symptom, under any circumstances. Now, Asher put them back. I've had a knock. Looking at listening to our three expert Gaelic players, it was interesting, and that I'm not even sure now that the concussions that they had, because they are warriors, there wouldn't be, if the same concussions happen now, not the one where there was loss of consciousness, there'd still be a tendency to want to go out there, and we have to get rid of that. But we're well on the way, and today has been novel.
I'm interested, Mickey, in what the impetus was for UPMC to become global experts. Where did this come from? Where did the decision to focus on concussion? What's the history of your organization and why you ended up focusing on this?
Oh boy, that's a long story. I was very, very fortunate. In the late mid-1990s, I had played sports in college, was interested in the brain, wanted to figure out how I could combine these two things, somehow maneuver a situation where I was doing sports concussion. And I happened to land at UPMC in 2000, and that was before a lot of people cared about this injury. And it was the culture at that time. We didn't know much, and I would spend a long time arguing with parents about taking we need to take the kids out of play. And we really didn't know much about the injury. And fast forward 16 years to this point, and all the research that's been done, the progress that's been made, the things we've learned, and seeing the pendulum swing so rapidly, so wildly to the other side has just been such an interesting story to me. And the reality is the truth is somewhere in the middle, like I talk about. But this is I think that we have a lot of work to do as clinicians to get the right information out there. I see a very strong need in Europe for that to happen. I feel that the knowledge level here needs to be improved upon in terms of the treatment and what we're learning in terms of active approaches. And just talking to Seamus, I talked to him before he came up here, and this conversation with him shows how much work we need to do to educate. And I think today has been an incredible step in that direction. I think at the beginning of the day, I thought that there was going to be more questions that arose and answers today. and I still think that's the case. There's a lot more. This should be step one, and there's so much more work that can be done to improve the level of care. And I'm hoping the relationships that have been developed here between UPMC and Bon Secours and the GAA can foster something special.
It's interesting that even when there are people with your level of expertise in the States to go and speak about what the truth of the situation is, that the pendulum has still swung that far. And in the media, I know that if we're talking about whether or not we're going to cover a concussion story, fatigue sets in quite quickly, unless it's something new, unless it's something that we can actually pin a story on and explain it to people in a very straightforward way. And maybe that's the next step, where there's a really clear, easy way to communicate exactly what the situation is. People get confused quite a lot by what the situation is and what the best information is.
But there's real coherent information, and I think there's real advances, and it seems to me there's a lot of open minds here to improve that. So I'm excited about it.
Okay. Kevin, today, obviously, you've been instrumental in putting this together from the GAA's perspective and putting the guests together. What have you learned?
I've learned that concussion is an evolving science, that it's never going to stand still, that it's going to keep evolving, that there are going to be a lot of different specialties involved that all have to work together for the benefit of the players. But most importantly, for us in the GAA, that education, we just cannot over-educate. Education and awareness are the most important things.
It's a job of work. It's an ongoing, everlasting job of work. And I guess there's two parts to it. There's the elite players who are going to be the example that everybody sees on TV. And then there's the kids who will then grow up in a culture where that's what the new culture is. They're difficult things to manage.
Absolutely. But the first step is just having this poster up in every dressing room in the country. I think it was Ryan Mellon made a very good suggestion there. He was saying that you could actually have this poster laminated and have it in a dugout, and sort of, during the course of a match.
Professor McMulloy, what have you made of today so far? As somebody who obviously has been involved for a lifetime in this.
Yeah, well, first of all, I think that there's a lot of information out there. That's my experience of it anyway. That I know the International Rugby Board have a huge amount of information and translated into 7 different languages. So it's out there, and it's been dispersed in all the sports in Ireland, as far as I know, and I've seen them in lots of dressing rooms. The players, obviously, and it's been mentioned many times today, they have to take more responsibility. They have to be aware of this and want to do the right thing. And I think the team doctors need to have an arrangement with them in advance that if they suspect they've got concussion, the player must respond and come off the field. That's been my experience in the past, that it works that way. They mustn't question it, because they're not in a position to question it, and there must be no undue influence from the coach or the manager, which there always is, by the way.
It's hard, isn't it? Because it's such an emotive thing. We've seen, and we've always seen that players get very annoyed with the team doctors when they get taken off. In big games, we've seen it, and we've seen our best players who are warriors, and we've seen the crowd respond to them when they do get up after concussion, and the crowd goes crazy, and that's just part of the sports culture that really has to be eroded.
Well, my experience was not to be attached to the coach. I never had a direct link with the coach. I made the decision without the coach having any part in it. I think that's the easiest thing to do. The most important thing for the player, from the player's point of view, is that somebody makes the decision, not them, and it's decisive, and they come off the pitch, and that is the diagnosis. If you've made the on-spot diagnosis, in my view, that's enough. All that happens after that is rehabilitation, reevaluation, management, and so on. I think once you take them off, that's the decision. That's the time to make the decision as well, incidentally.
It's the player who we've heard wants to stay on, and the player feels like they're letting their team down by going off. It's so hard to get that out of the players' minds.
But it's your decision, and I think you tell them in advance that in the situation of concussion, I've had experience of some very experienced rugby players, and told them in advance if I make the decision, and they never questioned it. Some of them were unwell afterwards, some of them weren't too bad afterwards, some of them mightn't have been concussed.
Yeah.
But at least they've been taken off, they're taken away from the risk of further injury, and they do appreciate that. And now, unfortunately, we have players in all sports now saying, well, I wasn't managed properly in 1955, and that's gone back a little far, but 1985 or 95 or 2005. And I think we have to be aware of that our responsibility, certainly for the medical physios and doctors' point of view, they have to make a clinical decision. I go back to that all the time. because I was involved with the concussion statement the previous second last time, and that was the one thing we made absolutely clear, that it was a clinical decision, that all that information in the concussion and the statement was helpful, advisory, but it wasn't conclusive. The conclusion was yours. And I think that's the message that I personally feel should be made very clear.
Mickey, it seems that you're sceptical about the ability of the world to come together for an agreed definition, or certainly the one that we have at the moment is outdated. I think everybody would agree with that. But is your concern that maybe if you feel like there's a job of work to do in educating Europe generally, that maybe it doesn't make sense for everybody to have the same definition just yet, that actually one centre should plough ahead and be the world leader and let everybody play catch up?
No, the international consensus statement is 4 years old, 5 years old. There's a lot that's been learned. Frankly, in 2011, I didn't know half of what we reported today. So I do feel that this meeting in Berlin will be able to translate that new knowledge that we have, and I'm confident that we're going to see a lot of improvements in that statement. But I also do reserve judgment until I see it come forth, because there are politics involved, there are people, and I just want to make sure that we keep pushing the envelope forward, and the international statements haven't done that to this point to the level I think it should have, but I'm hoping that occurs this time.
Who's stopping that as a matter of interest?
I'm sorry?
Who stops the envelope from being pushed? Who is...
Oh, I don't know. I'm not involved in the internal politics of that. But it's a lot of different people. And when you get a lot of different people in a room, it's hard to come to agreement that the sky's blue, and that does happen.
It's never blue in Ireland.
Yeah, true. But we ran into some of those same issues with our meeting that I reported on earlier. We weren't able to kind of push the envelope as hard as we wanted because there's kickback to that. So that's science. Science, it needs to be done the right way and needs to be moved forward in a responsible way. So I'm open to that process and seeing where it unfolds. But I know that we've made a lot of progress in a short period of time, and hopefully we continue to see that occur.
Barry, do you feel that international rugby has caught up, is beginning to catch up to this issue?
Well, I think it's between a rock and a hard place with this ongoing trial and experiment. The education that they send out, and which goes down in the pyramid to the clubs and is extremely good, but they don't follow it themselves with having these trials. 1 year 5 minutes, the next year 10, and then 13, which hasn't got a scientific basis, and it's sending out a very bad message to parents and kids. And that looks as if it's all right, and it's minimizing the seriousness of concussion. So I think we've got a long way to go, and I hope to pick up the kind of information that we're getting for the States. And just to go on Mick's point about the doctors being more firm, I worked closely with Mick when he was the Irish team doctor, and he is a man who has no problem with this, and he had the seniority and the expertise, but that's the kind of man he is, and he would not be influenced, and neither, in fact, would Kevin by anybody else, but that's not true across the board, and we've got to work a little bit on that. We also, the horror of what happened in the European Cup in the Harlequins match 3 years ago, where the doctor actually lacerated the player to get them off that was under pressure and subconscious pressure from the coach, and every occupational health physician, the most ethical occupational health physician, feels a subconscious pressure to come down on the side of the company. And if the coach, and again, some coaches are very, very difficult, want the player back on, they do put the doctors on it. We've got to get rid of that altogether.
Yeah. It's a tricky enough situation, Kevin, really, isn't it?
Yeah, just one point that I want to pick up on that Mick made there as well. And I spoke to the Galway team doctor about this. At the start of the year, I gave a brief talk to the players about concussion. And then the manager, Rory Gallagher, told them that my decision would be final. There was if I said they were coming off, they were coming off. I think that actually is very helpful, because the player knows then that they know in advance, first of all, so they're not going to start arguing.
Yeah. Do they ever self-identify? Like, have you got to that point yet where they're saying, look, I'm a bit symptomatic?
No. I'll be very honest.
Do you think they would?
I do. I do think so now, yeah, certainly.
Yeah.
Yeah. Some of the more experienced lads, certainly, that have been around for a number of years, yeah.
What was the shift in that culture then? Why do you believe that happened?
I think there's been a number of incidences. I think during the year, one of the things that I went to training when I even defined them all, talking about a female player who'd just died just earlier in the year, a female rugby player in the UK who died from second impact syndrome.
Yeah.
And suddenly that made it all very real for them. Even recently, the mixed martial arts fellow who died as a result of a head injury. So suddenly they realised that this is something very, very serious. You know, it's not something that I might have a strange complication 30 years down the road. You know, suddenly they realise, yeah, this could be very real.
Yeah, okay. Anybody in the room with any questions at this point? Yeah, I got a couple here. So maybe there's one in the middle first and then one in the back. And then there's one here as well.
Thank you. And just firstly, thanks to every speaker and everybody involved today. It's been fantastically informative and has really, I suppose, opened many of our minds with regards to concussion. It's a question, really, a GA question to Dr. Kevin. Taking what we've heard today and your excellent talk and what has been mentioned in a number of questions from a few people here, with regards to the controversy with regards to on-field decision-making, would it be sensible or easy for the GAA to take on board what we've experienced in our compromise rules or international rules experience, where there can be roll-on, roll-off subs, permitting, taking in context that it removes the tactical, I suppose, the tactical side of things with regards to mismanagement of the situation, taking into account that you're not putting the maximum pressure on the medic in question. You're removing, I suppose, any negligence on behalf of the management. But my experience from involved for a number of years, it in a multifaceted way, it could improve the situation whereby your panel of 21 or 22 players are involved more regularly. It does permit you to take any player off immediately, where you might have a less pressurized situation to make the decision.
I agree completely with you, Ronan. I have experience of both. Desi Farrell, actually, at the last medical committee meeting, brought this very subject up and suggested this. So great minds think alike. I absolutely agree. Now, the catch could be that it might be seen that the stronger counties like Dublin, this would be brilliant for them. They can continue to rotate 5 or 6 players, whereas the weaker counties like Donegal would have difficulty with that.
Can we vote about that?
Yes, and can I, please do. But I want to make one other point, Ronan, with regard to what I find difficult on the pitch is, for example, in the last game, Michael Murphy and young Gillespie collided, and Michael got hit side on the sternum and the rib cage. And I wasn't worried about concussion because it was fine from that point of view. But the kind of pain he had, I was concerned that maybe he had a collapsed lung. So I took quite a bit of time watching him. And so that is the kind of a situation where it would be great to be able to take somebody off, listen to their chest and check them out. The other situation I find is blunt abdominal, when they get a knee or whatever to the abdomen, the muscles in the abdomen go into spasm, and it can be very difficult. Somebody could have a ruptured spleen, could have a split kidney, and you're not going to know that. And I mean, as a surgeon operating on these things for 25 years, I should be able to pick this up, but certainly in that situation it would be great to take somebody off. So there would be more reasons than just concussion for rolling somebody on and somebody off. But again, I can see where the argument would come from, the weaker counties.
We had 2 more questions. There was one at the back and there was...
Yes. Hello. Tim Ryan, I'm a retired surgeon. In my training would have been in relationship to a head injury, examination, neurological deficit, CT scan. Okay. Now we're hearing today that it's head injury, examination, neurological deficit, concussion, watch him and look after him. Now there's a danger there in just missing possibly more important things than concussion. And I just wonder what the panel think about the role of CT scanning in head injuries at that initial stage.
Yeah. Mickey, maybe you might just take this.
Yeah, I mean, I think CT scan is absolutely critical if there's any neurological deficit. A cranial nerve exam shows problems, or the suspicion of a worsening condition. That child needs to be CT'd. You know, worst headache of life, vomiting, seizure, you know, decompensating over time, confusion. Those patients need to be CT'd. And I don't think anything we talked about today, maybe the focus is on the concussive piece of this, but it's all within the context that the CT's normal, you know. So hopefully that was made clear. But I agree wholeheartedly with you.
So the hockey player would have had a CT scan before, and
He did get a CT scan at the emergency room, yes.
Okay.
Yeah.
did you want to come in there, Mick?
So I was just going to comment in terms of, you know, long term. We're talking about bringing the patient off and the immediate management, having excluded any significant underlying problem. The MRI scan is the next most important test because the CT is more accurate for fractures, whereas an MRI scan is a more detailed scan. But one of the reasons we've set up those clinics is because in these two hospitals at the moment, they have functional MRI scanners, an additional MRI scanner that looks at the brain in great detail. But also they can have EEGs done. They can actually have the eye test done. They've got everything done at the same time. Not everybody can actually attend those clinics, but it is possible. In both cases, there's a research registrar taking the calls, monitoring the calls, and making sure that priorities are reached for all of them. And they can. It's a multidisciplinary approach after that. And Niamh, you're part of the scene with us as well. So it's a multidisciplinary approach. Then that you have all sorts of experts: neuropsychologists, a neurologist, adult, pediatric, neurosurgeon. You have all those people at your fingertips if you need them. And all that picture is put together. Neuropsychologists as well, which are in short supply in Ireland and are only available really in academic psychiatric departments. So in both those instances, there will be somebody available. So it's important for us to look down the road and monitor those patients. And we've already done a couple of school teams, rugby schools, detailed evaluation of all of them, including the MRI scan, and then you follow them longitudinally. And that'll give us the answers and maybe relieve our worries or make us more worried about the future. Because we did have one rugby player who did have chronic traumatic encephalopathy, but it's not something that's been reported in other sports, which is interesting, ice hockey or Australian rules. But we did have one in Ireland, so we are highly sensitive to that situation. And it's important that we monitor and follow through and obviously continually feed the information back. I'm hopeful that the Berlin meeting will take it a step further and will tell us more about the brain. For instance, the Trinity Group are looking at the blood-brain barrier. They've done a lot of work on a mouse model of concussion. So that's the kind of research we need to take it further.
Okay, we've got time for two more quick questions.
Yeah, I just wanted to ask Mickey if there's any advice for the role of diet and supplementation, particularly in post-concussion syndrome.
If there is, we don't know exactly what role that plays. One thing I haven't talked about today is how important behavioral regulation is to concussion management. And we recommend 5 things occur straight away after a concussion. First of all, regulated sleep. We don't want naps. We like them to fall asleep same time, wake up same time, be very consistent with their sleep schedule. Hydration, we like that. We like dietary regulation, not necessarily what you're eating, but making sure you don't miss a meal. We like exercise and we like reducing stress. All 5 of those things mitigate against migraine, and migraine plays a strong role after concussion. And so there's no good data on specific dietary considerations and outcomes from concussion, but more work should be done, likely.
Okay, I lied. We've time for 2 more quick questions. So one over here and then...
I know that in football, maybe at the top level, and rugby, and definitely American football, there's kind of wearable performance trackers or accelerometers on the players. I'm just wondering, does this factor into any diagnosis? Does it help at all, or is there features that you wish this technology had that it doesn't have yet, but it might have at the next National Concussion Symposium?
I addressed this a little earlier in my talk, and we see kids that get injured at 50 Gs and someone gets a 110 G hit and has a smile on their face. There's a lot of differences in terms of outcomes. And it really, a lot depends on what you bring to the table. You know, history of certain factors, we feel that less biomechanical force is going to cause injury in those people. So long story short, there's no threshold. I think accelerometers are a good research tool right now, but they're certainly not ready for prime time in terms of using them clinically.
Mickey, is there any point where the Steelers start at the combine rooting out those players who have that set of characteristics and decide we're not going to take you because we think you're going to?
You know, it's a great question. The answer is no, but I wonder if it's starting to come to that, because I've been asked to meet with the general manager and such and say, hey, this guy's got this history, what do you think?
Yeah.
You know, so that information is starting to at least be in a conversation. I don't know if we have enough data completely to make firm decisions on those things, but clearly there are some risk factors that are very real with this injury that we
maybe
presented
if
today.
it's 50-50 between two players, the one with the history of concussion, you don't pick him.
It's
Yeah,
interesting.
or beyond concussion, I'm talking like car sickness or
Sure.
history of lazy eye, or you know, those sorts of things. Yeah.
It's interesting research which has come out in the last couple of weeks about a reasonably big research project across the United Kingdom on players who had come back to rugby over the previous 2 years after going through what was considered to be the right concussion return to play regime. It wouldn't be the Pittsburgh, but it would be the best sort of we had on that. And their chances in the following year of getting some other kind of injury was 60% increased. Now, that's not necessarily due to the concussion, but what is it due to? You know, so further research needs to be done on that. And this may well refer to sort of players getting future contracts after concussion, and the manager knowing he's going to not get another concussion, but he's going to get lower limb injuries. You know, so there's a way to go.
Yeah, I'm in agreement with you. There's a fertile research area there.
Sorry, just in relation to someone that's gone off.
There you go.
Sorry, in relation to your question, it is possible to measure contact forces, but the accuracy is in question, and it should be possible from the information we have in road traffic accidents to calculate what a significant impact force is. I mean, the rugby impact are very similar to American football now, are they? So they're very high. That's up into the car crash range. It should be possible, if that was monitored, for the medical officer or somebody else touchline saying this is a significant event, even if the individual isn't apparently injured. That's, I think, is the way it's going. And we did a survey on some years ago on rugby contact in the scrum, where there's 1.5 tons in opposition, and it was possible to put on sensors and measure the pressure each individual person and the collective group were doing at the same time. It's obviously easier in the scrum, but it should be possible to apply it across the field for every sport.
Okay. Sorry, one last point. Yeah.
Thanks, Ian. I think about 3 months ago, the American Journal of Sports Medicine, there was an article about pre-season 5 DHEA, I think, being used, and the incidence of concussion was lower in those who used it than those who didn't. Do you have anything on
I
that?
have seen that study. Anthony, do you know the results of that study? Because I'm not intimately familiar with that.
Do you want to just repeat the question? Sorry.
An article in the Journal of American College of Sports Medicine about 3 months ago about pre-season 5 DHEA. Those who took it had a reduced incidence of concussion compared to those who didn't take it.
Yeah, I'm not familiar with the methodology on that.
What is 5-DHEA?
It's an amino oil.
Okay.
So it's a supplement associated with fish oil.
Yeah.
And we've been approached numerous times by companies selling this to do research, and as soon as we say randomized control trial, placebo results will be published no matter what, they head for the hills. And the reality is we know several of these trials that were conducted earlier that were not successful. I'm not familiar with the trial the gentleman spoke about. I'm not familiar of anyone in American Journal of Sports Medicine, so I'll have to look for that. But there's limited, if not any, evidence. I mean, there's almost no evidence for these types of trials.
There's a lot of things that are going on right now in this space where everyone's looking for a quick treatment, and I don't think there's anything that's been proven, at this point in time in that respect for bettering outcomes.
So fish oil is the new snake oil, is what I'm hearing.
That's what you heard.
Yeah.
Can I pick
Okay.
up on-
Yep. Yeah.
Pick up on one point made by Mick. You can measure the G-forces now on GPS. It's not that accurate, and certainly there isn't a direct correlation, a direct linear correlation. The point that Seamus Callanan made earlier is very interesting, and we're finding this as well. Players are bigger and stronger, but we're not seeing more concussions because of the static impacts. In other words, if you look at the law of physics, the kinetic energy dissipated is half mv squared, half the mass multiplied by the velocity squared. So the most important factor here is the speed. And that takes you back to Owen Cadigan and Lee Keegan. So this is where, and this is something you're watching from the sideline as well, the speed at impact.
Yeah. One of the things speaking to people at lunch was that sometimes the view isn't great, that the doctors are being told to sit down by the fourth official, that their managers and the selectors are in front of them and they're like trying to see what happens.
Well, there was an issue a few years ago that has now been resolved, and I have to say nobody has ever obstructed me on the sideline, even though I move up and down. So, I wouldn't accept that.
All right, okay. That's just.
Could I just make a comment? In rugby, the doctor and the physio can go onto the pitch anytime they like. They don't have to ask the referee. They can go straight on. Both of them or one of them, doesn't matter. Just want to think that we should mention prevention of head injury, shouldn't we? I mean, we're talking about managing it, but I think lots of sports have a major problem facing them in preventing the injury, in other words. And the techniques of the game, the rules of the game have to change. And rugby is one of those sports.
And isn't rugby going to suffer because less and less children are learning the basic skills? They're coming to the sport a little bit later. Instead of having the grounding as a 10-year-old, 12-year-old, they're now coming to the sport at 14 because their parents aren't allowing them play.
That's true, but there are some practices where the laws allow people, set them up in a very high-risk situation. I think that's very obvious when you look at it in television. It's, we've seen programs in the past where you measure the contact. We can actually record it stage by stage, and you can see where the risk occurs, and the risk for head injuries occurs. Any injury to the shoulder or neck or shoulder is the danger area. But we know that in not sports, it's possible to minimize that by avoiding head contact or minimizing head contact.
Okay, ladies and gentlemen, that's your afternoon panel. Please give it up for Dr. Barry O'Driscoll, Dr. Mickey Collins, Dr. Kevin Moran, and Professor Michael Malloy.